Again, we're going to use the microphones in the room, so if you have questions, but this is your chance to ask tough questions of our panel. You've already met Dr. Weir, and I'm Chang, is a pediatric gastroenterologist at Boston Children's Hospital who specializes in a number of areas. The one I like the best is celiac disease, both diagnosis and management. He has research interests that include the diagnosis of potential celiac disease, and maybe we'll ask him what that means. Also, accuracy of diagnostic testing, and most recently is doing a study on polyautoimmunity. We've heard about patients with multiple autoimmune conditions. Jaclyn Quinlan is a registered dietitian specializing in celiac disease at Boston Children's Hospital. Her interest in the gluten-free diet was sparked by the potential nutrient deficiencies and associated pitfalls. I'm going to let you tell your own story if you want, Jaclyn. Her passion for the gluten-free diet has continued to grow over time. And then Melinda Denis, Melinda and I are old friends. She was diagnosed with celiac disease 20 years ago and really is a leader in the celiac community. She's the nutrition coordinator and a founding member of the Celiac Center at the Beth Israel Deaconess Medical Center. She lectures nationally and is a nutrition coach and consultant, and we're very happy to have her with us today. So I have a number of questions. I'll try to keep my eye on the microphones. Okay, so we're going to go down the road, Dr. Chang. There's a question that was submitted that says celiac disease runs in our family. After our daughter was diagnosed, we were all tested. My son had a positive TTG test, but his biopsies was normal, and he was labeled as having potential celiac. Can you tell us what that means?
Absolutely. For potential celiac disease, the definition is essentially someone who has positive blood markers for celiac disease, and most commonly that's going to be the TTG IgA. But as we've all sort of heard this throughout today's session, is that there are other markers like EMA IgA and TGP IgG. But those individuals, when they have a biopsy, have normal, or what I like to call equivocal or sort of borderline biopsy findings. And so I think it's important to know if someone has celiac disease and two, doesn't have celiac disease. But I also think it's important to know those who have potential celiac disease, which essentially just means that some of the studies in potential celiac disease in children have shown that some of them, while still continuing on gluten, go on to develop celiac disease, while others, while continuing gluten, go on to not develop celiac disease, meaning their blood markers normalized and they never develop any symptoms. And the way that this specific group sort of performed this study was that they had a specific protocol where after a diagnosis of potential celiac disease was made, they kept monitoring them on gluten and then had repeat labs, but also repeat biopsy. And so I think this is where, again, we know what the management of celiac disease is like, a strict gluten-free diet, but this is where I also like to emphasize the management for potential celiac disease is to really personalize the treatment and management and also follow them over time. And I think this is where, going back to Dr. Leffler's talk, who started off the morning with an excellent talk about sort of the diagnosis of celiac disease, we still do recommend a biopsy, especially in cases where the markers are not super duper high, because individuals can certainly fall in this category. And before sort of jumping to conclusions saying, hey, I have a positive blood marker and I must have celiac disease, you really want to know which of these categories you fall into. So yeah.
Great, thank you. Dr. Weir, So we have a number of adult primary care physicians online, as well as some primary pediatric care providers. And a question has been asked multiple times. So if one of these primary care providers suspects celiac disease, should they start the testing in their office? Should they wait and send them on to a gastroenterologist? Why don't we start there? There may be a sub-question.
I think this goes for all primary care doctors, but also specialists. If you're worried about celiac disease, please send the serology. Certainly, we do sometimes see people with celiac disease who are more complex and may not have positive serology. If you're concerned about celiac disease, even if your serology is normal, please then send them our way. And obviously, if the celiac serology is positive, please send them our way as well. So I think definitely I would start there. The test that we recommend sending, as we've talked about before, is a tissue transglutaminase IgA and a total IgA. Because if the patient does not have enough IgA and has what we call a selective IgA deficiency, you may not be able to trust your standard serology. So we recommend starting with those two tests. There is also sometimes perhaps a role of sending an endomysial antibody IgA, and that comes into play, particularly with patients who have very high TTGs who may not be interested in endoscopy, but that is a little bit more complex and probably not recommended universally in screening.
Great. So one of the docs sent testing on a patient, and there was a positive IgA TTG, but the patient was also anemic, and that was found at the same time. Should the doc start treating the iron deficiency?
Yes, please. We would recommend going ahead and treating any deficiencies that you find, particularly iron deficiency anemia. What we would not recommend is to go ahead and initiate treatment for presumed celiac disease with a gluten-free diet without seeing us and without more discussion and evaluation.
Great, thank you. So, Jaclyn, this parent of a child with celiac disease wrote that the school nurse said that gluten-free food isn't available in that child's public school cafeteria. Aren't they obligated to provide gluten-free food?
Yeah, it's a great question. And I think talking about reasonable accommodations and what schools are supposed to be providing with diet restrictions. And so, of course, it's helpful to have a 504 plan and some official documentation. But in the short answer, yes, gluten-free options definitely need to be available. It might not be an exact one-for-one replacement. For example, if raviolis were being served, it might not be reasonable to expect that gluten-free raviolis would also be on the menu, but a hot meal for a hot meal and still meeting the standards for the National School Lunch Program is expected with diet restrictions.
Great, thank you. So, Melinda, a lot of people pre-gluten-free diet depend on wheat as a source of fiber in the diet. Can you tell us some ways in which you could incorporate high fiber foods in a gluten-free diet?
I'd be delighted. Yes. We know the dangers of the low fiber in the gluten-free diet, right? You see maltodextrin, modified food starch, and tapioca starch, and rice flour, and all those. Fortunately, there are many options to find fiber in the gluten-free diet. And the primary ones I like to talk about first are the gluten-free alternative grains. Some of them are pseudo grains, but they're all high. So amaranth, millet, buckwheat, teff, sorghum, and quinoa. Thank you. Just make sure that they're all labeled gluten-free when you purchase them. So those grains are wonderful, and we're not always as familiar with getting those into the diet. Also, obviously, all your fruits and your vegetables, your nuts and your seeds. I'm thinking especially of pumpkin seeds, sesame seeds, things like that. Flaxseed, ground flaxseed, chia seeds, of course. And then, of course, your legumes, your dried beans, so your chickpeas and and lentils. Those are all so plant forms of dietary fiber. Some of the quick ways to get them in, you can go very simple, and you could mix half of your rice with quinoa one night just to boost the nutritional value exceptionally. Or you could go and massage kale, another great fiber source, with avocado until you got it nice and wilted and made a beautiful salad with lemon juice and salt and olive oil. Like, there's many different ways to get these things in. I don't have enough time to mention all of them, but starting with the grains and going gradually and making sure that you drink adequate water as you're advancing your fiber would be the best way to start.
Great, thank you. Can we go to the microphone?
Hi, I'm a practicing nurse practitioner, but also have a 6-year-old daughter that was just diagnosed with celiac disease about 5 months ago. And she was a baseline picky eater already, and has some deficiencies where multivitamins might be an option. But I had read somewhere that gummy multivitamins might not absorb with celiac patients, and chewables are a better option. Is that true? And is there a recommendation for gluten-free chewable multivitamins?
Yeah, I can take that question. It's a great question. And I always recommend the chewable version as the preferred version. They tend to be more complete in terms of the vitamins and minerals that are in the chewable version as compared to the gummy. And I don't think that we really know if the gummies are better absorbed or worse absorbed than the chewables. But a brand that I typically go for is the Target Up and Up children's chewable multivitamin, and it has iron in it, which is nice for anybody with iron deficiency too. Yeah.
And do you recommend a probiotic with it or a combination? Is it necessary for children?
I typically recommend food sources of probiotics versus a supplementation. So some yogurt, kefir, fermented vegetables could be nice options. I typically don't lean into supplements too much for probiotics, not a lot of data to support them.
Thank you.
So you may not know this about Dr. Chang, but he is, what's it called when you go viral? An influencer?
I don't think I'm that.
He's a TikTok influencer. And the question I am going to ask him, he has answered on TikTok. So if you need a refresher, you can find him there. So how bad would it be for your intestine to eat gluten once a month if you have celiac disease?
I think that's a really great question. And so similar to my answer on the TikTok was that gluten exposures happen. It can be intentional or it can be unintentional, despite everyone's best efforts. And I think Dr. Weir really talked about that. And again, the reasons why we recommend to avoid gluten, that it causes inflammation, and there's long-term implications of that. Just like any other medical condition, the gluten-free diet is a prescription. And just like how we would treat any other medical condition with a prescription, we don't say, oh, take this when you remember it. We say, take this blood pressure medicine every day, or take this medicine every day to help treat your condition. And I don't think the gluten-free diet is any different. With that said, it's not an uncommon question I get answered, especially as a lot of our patients sort of grow older and they go into adolescence. And again, it's not easy always to adhere to a strict gluten-free diet. My biggest concern in sort of, answering or addressing that question is if I were to allow this individual to have gluten once a month, again, there's no data really to say what the long-term implication of gluten exposure once a month. But then when you sort of go from a black and white to a gray of having, okay, once a month is okay, I feel okay, I'm going to do it twice a month and 3 times a month, then I think that's a very slippery slope. And we know that there's a lot of long-term implications of that, especially if you're not experiencing the symptoms. And so I guess my best answer is, it's not dangerous or life-threatening, but like the words of Dr. Weir, it's hard, but it's so worth it. And so I'd recommend, sticking with the prescription. And again, there's a lot of benefits for it in the long term and in the short term.
Great, thank you. And we're in, yeah, go
I
ahead.
think I agree completely with everything you just said. The only other thing I would say is that we're not always in complete control of the gluten exposure that we have. And, the gluten-free diet is imperfect. And so what I try to emphasize with my patients, and when this question comes up, is control the things you can control to reduce the amount of gluten that you see, because it probably does have long-term value.
So hang on to the mic, Dr. Weir. Back to the issue of what should a primary care provider do and what should the celiac expert do. Can you tell us about follow-up lab work? Is that something that should be reserved for the gastroenterologist, or could we conceive of some coordination of efforts with the primary care provider?
I think we really see ourselves as working together. We certainly want to see our children with celiac disease back for follow-up. We recommend, once someone is stable and doing well on an annual basis, and that is one to send off labs. The monitoring labs that we typically send as we follow the TTG is a rough marker of intestinal healing, not perfect, but a good marker. And then also to see how they're growing and how they're feeling. But it's not just the labs that we send. We also want to help families at different stages of development address the different challenges related to the gluten-free diet. So I really value, sometimes patients come in and already have had the labs with their pediatrician, and I think that's great because I have that information right in front of me at the time of the visit. But it's not just about the labs. And I think sometimes what can happen is that patients can get the labs with their pediatrician, but some of that additional assessment does not happen.
Can I add
Yeah.
one thing?
Please.
And also, I think this is also recommended as part of all the pediatric and adult guidelines, but it's not just follow up with a gastroenterologist. It's really a multidisciplinary follow-up. And so again, it may not mean you have to see a dietitian every single time you see a GI doctor, but again, especially in children, especially as they grow older in different developmental stages and where they are in their life, their diet changes. And so there are potential perils of a gluten-free diet when it's not something you may necessarily need, or your diet changes. And so you might be at risk for certain deficiencies. And so I think as part of the follow-up plan would be to also think about following up with a dietitian to see how preferences, but also dietary needs and things like that change.
And I maybe didn't completely answer the entire question about what labs to send.
Okay, go ahead.
One is the TTG that we like to follow, but then also we will often follow other things like thyroid function, because patients with celiac disease are, as you know, are at higher risk of having other autoimmune disease. In New England, we will also screen vitamin D, because vitamin D can be low in patients in New England in general, but particularly in patients with celiac disease. And because they have increased susceptibility to bone disease, we want to really make sure that that's adequate. And so those are some other labs that we will frequently send in addition to the TTG.
Dr. Weir,
Mm-hmm.
So if the pediatrician or nurse practitioner or adult doc sends a TTG, do they have to repeat the total serum IgA?
Probably not if it's already been done.
Great, thank you. Oh, yeah, hi,
Yeah.
please.
Hi, it's a little
Oh,
loud.
we'll go next, yeah.
Is there any room for routine DEXA screening in growing children to look for the low bone density beyond just 25-hydroxyvitamin D monitoring?
I'm sorry, I didn't totally hear.
Is there any room
question.
for DEXA screening, for DEXA
Oh,
scans?
for DEXA, yeah. Routine DEXA screening, I think, is a little bit controversial in celiac disease, and it is not routinely recommended, particularly for children. The data suggests that while children can have decreased bone mineral density at the time of diagnosis, that usually resolves or improves significantly as the patient is on as a child is on a gluten-free diet. I will send it in patients who are really struggling with adherence, or patients who have a very strong family history of bone disease, or who are having a series of unusual fractures, but it is not something that, at least in pediatrics, we do routinely.
Great, thank you.
Great.
I just had a question about genetics, DQ7 specifically, with a significant family history, both parental siblings. You know, one of mine is consistently symptomatic, but we've done genetics and she's clear. Now with DQ7 I'm reading about, is there a reason for me to return to assessing this?
That's a really great question. And I think Dr. Villafuerte sort of talked about that, you know, DQ2 and DQA are the most commonly at least tested for, and that's what oftentimes is commercially available and in clinical practice. DQ7 is a pretty relatively new, I guess, genetic screening test. And so again, at least I'm not familiar with one being available clinically in clinical practice. Is more for research. But again, this is also where, you know, genetics is a role, but not, you know, a diagnosis nor ruling out a diagnosis too. And so the analogy I like to use is, you know, for celiac disease specifically, we have a lot of these great markers and great diagnostic things, but you just need to get all the puzzle pieces together. And I think that's another key puzzle piece that we're just finding out about now to help put the picture all together. And so if DQ2 and DQ8 are negative, but they're still having symptoms and you're trying to decide, do I need to, you know, go the extra step and do an endoscopy and a biopsy, and we're able to get the additional information, it could be helpful. It doesn't give a diagnosis, but it could be helpful making sort of some of those key decisions.
Great. So Jaclyn, this question reads, my son is a senior in high school and looking forward to attending college next year. What are some suggestions for planning ahead for food in a college dining hall?
Yeah, well, first, I just want to say I think it's wonderful that you're thinking about planning ahead. So most schools will now have dedicated spaces for gluten-free foods, which is really wonderful. I think as you're prepping and touring schools, it's always great to ask questions about what the school can offer for diet restrictions, specifically the gluten-free diet. Kind of thinking through your day-to-day where those options will be located, how is cross-contact handled in the school environment, in the dining hall setting. A lot of food service providers within schools will have a contracted dietitian on staff who will be very much knowledgeable in the gluten-free diet and celiac disease and be able to help guide choices. So I think it's always really wonderful to connect with that resource before the start of the semester, once you kind of figure out where you're going to school. So yeah, I think really just being your own advocate, asking questions when touring, and finding out the resources that are available. And then lastly, getting in touch with, once you do know where you're going to school, getting in touch with accommodations or disability services to get any documentation you needed, and think about maybe some living accommodations as well, such as having a mini fridge, microwave, things in your dorm room that can make just having diet restrictions or just access to food a little bit easier in these living spaces.
Great, thank you.
Can I follow up on her suggestion about asking questions when you're on the tour? One thing I would also say is when you're on the tour, don't just ask the school what the protocols are, but when they send you on the tour with the student, ask the student. Do they have celiac disease? Do they know anyone else with celiac disease or someone with food allergies or intolerances? And then find out what the real life experiences are from the school.
That's a very good point, Francie. Thank you. Melinda, we've heard a lot about vitamins and celiac disease. Do you recommend that all patients with celiac disease take a multivitamin supplement?
Great question. Actually, there's no standard recommendation for a multivitamin in the celiac population from pediatric to adult, but, or actually I should say no standard for adult, but recently the Academy of Nutrition and Dietetics released a statement saying in all populations, if it cannot be met by diet alone, then it is absolutely reasonable to recommend vitamins and minerals as appropriate. In my adult clinic, it's almost everybody, almost 100% of our patients are on vitamin D, partly because of where we live. And of course, the malabsorptive piece. And that's even after celiac is well treated on the gluten-free diet. But it's very common. What a dietitian will do is look at the diet recall and look at the labs and make a decision individually based on that patient's needs. And we know that the gluten-free, the nutritional deficiencies or inadequacies in a patient newly diagnosed with celiac disease are very similar to the deficiencies we see in the gluten-free diet itself. So there's a lot of overlap, right? Particularly when it comes to iron. As we heard earlier today, many of the products aren't fortified and enriched. So right there, you lose calcium, you lose iron, and some of the B vitamins. So I'm going to look at their diet recall very carefully. I'm going to look at labs very carefully and make an individual decision. But if I do recommend a multi, and I often do, it's a standard gluten-free multivitamin that doesn't have crazy amounts of anything in there. And it's, of course, it's labeled gluten-free, but I'm also going to look for what matches their needs. There's so many choices. Jaclyn already talked about chewable versus gummy, liquid, capsule, and on and on. And Dr. Weir was mentioning D. I would say iron is also one of the most common ones that we will supplement individually, as well as zinc. So zinc is a micronutrient, as you know. You only need a little bit, and we do it for a short amount of time. And then we retest so that nobody's left on a supplement any longer than they need to be. That's a big topic in a, tiny amount of time.
Yeah, no, great answer. I am at the risk of alienating my two colleagues from Children's Hospital. I want to ask a question. Actually, we got two of from in the last session, which is why two people sent in that they have two children with celiac disease, and one who, when inadvertently exposed to gluten, as vomiting, and the other one who, when inadvertently exposed to gluten, gets headaches. And so this is, I think, a challenging question, is why would some children react or adults react in one way and others react in a different way?
Go at it.
That's a really good question. And I think this is really, celiac disease is one condition, but it manifests in such a broad spectrum. And this is where, again, hopefully events like this, where we're educating not only ourselves, but hopefully everyone online, and just increasing awareness of the fact that, when we first learned about celiac disease, it was a primary GI condition with kids who were not growing and had GI symptoms. And now we know that there's many extraintestinal or outside non-GI symptoms. There's also a lot of people without any symptoms. I think, we're learning more about the biology of what happens at that moment. And again, some of hopefully the future will show like what happens immediately after a gluten exposure. And there's a lot of research looking into cytokines and chemicals and proteins. And all of those, I think, can help characterize like why it is that some people may have symptoms versus not. But this is where everyone's different, and so again, the best way I can answer this question is that everyone's different. It's the same condition. Same thing happens to the body when someone with celiac disease ingests gluten, but the response, what they feel, what they experience, the duration, all of that's very different too. And so we really try to look at everyone as an individual and use those as clues to sort of say, hey, is this possibly a gluten exposure, or is this possibly something totally different? Yeah.
So we want you to translate that to TikTok later. So I want to thank our panelists. We could go on, and I know all of them really well. And you get the last question. How's that?
I'm just wondering what family members of those with celiac should do in terms of initial testing and follow-up monitoring over time. The one piece of advice I've heard to the teen children of an adult who was diagnosed is that the teens should not be screened because if they haven't experienced the negative effects of feeling bad with celiac and they get positive tests, they won't really be as motivated to adhere to it. And the other is that if they get tested once and they're negative, they might think, okay, I'm good for the rest of my life and never get tested again. But I can see reasons why screening would also be good. And I just wasn't sure how often for parents, for children, they should be screened or be concerned and whether it's related to whether they have symptoms or not.
I can
Yeah, I
take
was
that.
gonna give it to you, Dascha.
So we recommend siblings of first degree family members with celiac disease be screened at the time of that family member's diagnosis. And then we recommend repeat screening approximately every 3 years. And that may depend a little bit on the risk or how much celiac disease is in the family, or sooner if symptoms develop. Because you're right, it's not that celiac disease is like a one and done, you either have it or you don't. It can turn on at various times. I think the screening for adult family members is more controversial. I tend to err on the side of recommending that parents get screened. And that is primarily because of my experience where a lot of families go gluten-free with their children or go almost not maybe completely gluten-free, but significant reduction of gluten exposure. And if I had $1 for every time a parent came in and told me that I feel so much better, Dr. Weir, and then they're already gluten-free and it becomes really difficult to diagnose whether or not they have celiac disease. So I tend to recommend that parents get screened as well. I also think that it's important that teens, even if they don't have symptoms, any teen or child get screened because of some of the things I talked about in my talk and bone health and various other things. And I think it's a disservice to teens to say that just because they're asymptomatic, they're not going to treat it. I think it's really challenging to have celiac disease as a teen. But I think that every day I see teens, both with symptoms and without, who do a beautiful job of it. And so I think it's important to get the information that you need, and then we can deal with how we handle that and how we approach that. But I don't think we should assume that a teen isn't going to follow the diet, because I have lots of examples where that's definitely not true.
Just remember that the rest of the people here may not like the fact that we have to shorten the break. No, but go ask your question.
I just one quick question, and it's related with heart disease, the correlation between celiac and heart disease. It hasn't been mentioned here at all, and there's a history to it, but it seems like it's been eradicated from everywhere. And anyway, I get an answer.
I'm a pediatrician and we don't see it in children, but on my review of the literature, there seems to be some increased cardiovascular risk associated with celiac disease. And I think that is primarily in the areas of myocardial infarction, but I think also atrial fibrillation. And I think the connection between stroke and celiac disease is less certain. And I think what's also less certain is the role of the gluten-free diet in the risk of cardiovascular disease. I just don't think there's enough research on it. And I think it would be a really interesting area, and it's an area that we need more understanding. I think some patients with celiac disease are more likely to not smoke, to not be overweight, to not have as issues with hyperlipidemia as other patients, as the general population. And so that may be protective in some cases for some of this, but I think there's just a lot of information we don't know.
Well, 4 or 5 years ago, I read all sorts of articles that Dr. Fasano had written about the connection. And now I find they're all gone from the internet. I mean, I came here just to ask him that question, and he's not here. So I have to ask him.
We apologize that he had a family event that superseded his coming. So you could always reach out.
Thank
to
you.
him. Okay.
Yeah, Alan, if I could just add that as part of our HMS Celiac Education and Research Program, we have a webinar library, and we have one specifically on the cardiac. So if you go to www.nca.org and click on the celiac disease webinars, you'll find that webinar. Okay.
Yeah.
I'll come over.
Yeah. Thank you very much.
Thank you.
So thanks, everybody. This is a really engaging session. Thanks especially to our panel members.